Today we are back with another episode. We are talking quite a sensitive topic. We are talking about recurrent pregnancy losses. Recurrent pregnancy losses, it's usually a devastating situation for both the patient and also us, the clinicians that handle it. So it's quite a sensitive topic that we are going to dive into. Try and listen and learn a few things. With us today, we have Dr. Medad Mwevesa. Dr. Medad, we are glad to have you on this podcast.
Thank you.
You can please introduce yourself to the viewers.
Good evening, folks. I'm glad to be here today to take us through one of the most sensitive areas of our practice as gynecologists, obstetricians, and also fertility specialists. Our topic for discussion today is recurrent pregnancy loss. It's a very sensitive area. People start homes, but actually what really happens is every time they lose a pregnancy, the anxiety builds.
Yes.
The distress in these homes is usually very palpable for both the female partner and the male partner. So I thought we would go through this rather sensitive discussion such that we enlighten us about its occurrence out there and what it is that we have available that can be done to give us a better outcome from this disastrous experience.
Thank you, Dr. Medad. So basically, starting from the top, what is recurrent pregnancy loss?
Thank you. I would start with what a pregnancy loss is. And basically, we would define a pregnancy loss as a demise of any pregnancy before the time of viability. Viability would define it as that time at which if a baby was born, we would expect that baby to stand a realistic chance, a realistic possibility of survival. Now that time varies from country to country, hospital to hospital, depending on the different capacities that may be available at all those different settings. Generally, in our Ugandan context, when we talk viability, we are talking 28 weeks.
Okay.
But in other countries that have facilities that are generally a little bit more advanced, viability, we talk about 24 weeks.
Good.
But much more specifically, you would consider babies that are born above the weight of 500 grams to be viable babies, to mean that we expect those babies to have a realistic chance of survival. So when we say recurrent pregnancy loss, we define that as recurrent pregnancy loss. We define that as 2 or more losses that a mother would experience in her reproductive life.
Okay.
We can either classify it as primary or secondary. Primary in a sense that this lady has lost those 2 or more pregnancies before she's had any pregnancy past the 20 weeks of gestation. And secondary, if she's had a few pregnancies, 1 or maybe more pregnancies, if she's been able to carry those pregnancies past 20 weeks before she gets to lose these other ones. And the order really doesn't matter. It may be consecutive that she loses those 2 pregnancies consecutively, or it could be that she's had 1, maybe had a child or 2, and then loses another. Yeah.
Okay. That is very, very well illustrated and classified. So, well, how common is this situation?
Oh, it's quite common. Generally, about 10 to 15% of all pregnancies in the general population are lost. Now, out of that, generally in a population analysis, you usually have between 1 to 2% of those lost pregnancies as recurrent pregnancy losses. It's very common.
Okay.
It's very common, it's very prevalent. It's one of those commonest complications that we deal with day to day in our reproductive healthcare clinics.
Okay.
Yeah.
So quite a common and sensitive situation for really the couples and also the doctors. So what's the impact of this on the couples and the health workers?
The impact is immense. It has a huge toll on the psychosocial well-being of these patients, on the psychosocial well-being of families. And every time a mother loses a pregnancy, it's not a pregnancy that has just been lost, it's a child.
Yes.
So this family, this mother, this father, they'll go through a process of mourning. And it hits differently for each different couple, for each different household. And the anxiety only builds and gets worse with every other loss they go through. The anticipation. Even when on the following pregnancy, on the successive pregnancy, even when everything seems to start off well, the anxiety is so high that the hope of finally getting to the finish line successfully is more or less zero, more or less not there. So it's a difficult experience. It's worse. It's a difficult experience for us clinicians. It's a devastating one for families, for couples that have had to deal with such.
Recurrent pregnancy loss, such an unfortunate condition. So having defined the condition, you said 2 or 3 more pregnancy losses. What are the common causes? What I would say, what are the risk factors?
Well, the causes, for the most part, on assessment, when we get patients who are faced with this unfortunate occurrence, the causes are not always obvious. What usually we are able to figure out are the risk factors that put these patients at risk of this unfortunate event.
Okay.
And now let's not forget that to get a baby, it takes 2 people. It takes, a male partner and a female partner.
Yes, definitely.
And some of these risk factors will cut across. Some are carried by either of the parents or either of the partners. What we know for sure, though, is that age of both parents actually is a very huge factor in the capacity to conceive,
Yes.
but also the capacity to carry these pregnancies to viability.
Yes.
And we know that optimally, the best age for a mother to have a pregnancy and to have a child is generally around 27 years. And we know that the capacity of these mothers to successfully carry a pregnancy actually drops very significantly after 30 years. Gets even worse when these mothers cross 35. But generally speaking, you would want to say that fertility in a female partner generally stops at 40.
Okay.
Much as we have even 45-year-olds, 44-year-olds who have been able to conceive naturally and have been able to carry these pregnancies without any major complications. Yes. And that doesn't only affect the female partners, but also the male partners. Increased paternal age, generally ages above 35, even in the male partner, are associated with issues in terms of sperm quality and the capacity for that sperm to successfully fertilize the egg and lead us to a normal pregnancy and a normal baby. So that's one issue of age. The other risk factor would be, so we've now known that increased parental age is a known risk factor for recurrent pregnancy loss. Now, we also have patient-to-patient social health behaviors.
Yes.
And in that line, we look at issues like stress, extreme levels of stress associated with very high levels of a hormone called cortisol, and this negatively affects the capacity to have a successful pregnancy.
Yes, yeah.
Along with stress, there comes extremes of exercise. Excessive exercise that is not modulated has been associated with unfortunate or bad pregnancy outcomes.
Yeah.
But also lifestyle choices, especially alcoholism. Alcoholism is not only associated with recurrent pregnancy losses, but it's also associated with sudden fetal death. But even when for mothers who have been lucky enough to have those children, excessive maternal alcohol consumption in and around the time of pregnancy and delivery is associated with sudden infant death. Okay. So alcoholism, both still for both partners, because like we said earlier, it's the forming of a baby takes the contribution of both partners. Then smoking. Excessive smoking or any forms of smoking, no matter the quantities, have been associated with the adverse pregnancy outcomes. There is also a well-documented association of caffeine intake. We know that caffeine is in coffee.
Yes.
But we also know that some of these, commonly these energy drinks that we have on market have significant amounts of caffeine. Some of these soft drinks that are on market also have significant amounts of caffeine. What we do not know is the exact amount of caffeine that you would need in your body to cause this kind of disastrous outcome. Yeah. So when it comes to pregnancy and caffeine, you're better off keeping it safe and trying to avoid coffee intake in as much as possible. Because you do not know how much will cause you problems. Okay. Yeah. The other risk factor would be some endocrine disorders that the mother may be carrying. Much more commonly, complications of the thyroid gland. Yes. Especially hypothyroidism or hyperthyroidism, where the thyroid gland is either hyperfunctioning or hypofunctioning. So that would be another risk factor. Course, yes. But also, when much more specifically, when it gets to mothers who tend to lose these pregnancies in the second trimester. Usually we define the second trimester as that time after the first 3 months, after the first 12 weeks of pregnancy. Classically, those are mothers who tend to have what we would call a weak cervix.
Okay.
And usually they will tell you, I was well, I wasn't sick in any way, I didn't have a fever. Then I was there and I just saw water flowing, water coming out. And then what followed was a miscarriage.
Yeah.
And usually the history is telling. And those are mothers that would classify. Unfortunately, at that stage, even when you do these tests, even when you do these scans, the sensitivity of these tests is rather low. So you'll tend to really get the diagnosis from the history. Unfortunately, by the time you get to the history, the mother has lost 2, 3, or 4 pregnancies, and they are falling apart. Yeah, so now those are mothers who have a weak cervix.
Is that what they call cervical insufficiency?
Yes, that's what you would call cervical insufficiency, and it's repetitive. Commonly, it presents early on in the second trimester, after 12 weeks of pregnancy. But again, from history, you are able to, some mothers will tell you the first pregnancy, especially for mothers who have secondary recurrent pregnancy loss, they will tell you, oh, I delivered prematurely.
Yes.
At maybe 30 weeks, the waters just broke. The next pregnancy, they miscarry. Usually, when you take time with these patients, they will tell you and you'll be able to come up with a diagnosis of cervical insufficiency.
Okay.
Yeah. So then there are also women who have congenital uterine abnormalities, where the capacity to the uterus to really carry these pregnancies, or even the capacity of the uterus to allow proper implantation, proper attachment of the pregnancy to its wall is compromised. And these come in forms of mothers who have like a septate uterus. A septate uterus is where you have the cavity of the uterus where the baby normally settles, divided into 2 parts. And this septum can be of different length, and it would cause differences. It would cause different outcomes depending on how deep it goes into the cavity of the uterus. But then there are also those who have like a congenitally short cervix. There are those who might not even have the cervix itself.
Sure.
But also some of these malformations could have been acquired later on in life. Like, for example, women who have had cervical cancer and have had surgery for the cervical cancer, where a big part of the cervix has been operated, and that causes compromise the cervix, in which case you're not able to, the cervix is not as strong enough to keep the uterus closed to carry these pregnancies.
Okay.
Right. Yeah.
So the risk factors are quite immense. Quite immense. Do the genetics play a part in these pregnancy losses?
Oh yes, they do. There are parents who have genetic complications, or who have, where their chromosomes have gotten disturbed along the way in terms of acquired changes to their chromosomes. But some are also born with these genetic derangements.
Yes.
And in which case those mothers, those patients would be able to pass on these genes through their eggs to the pregnancies. And if those genes are not compatible with life, then these mothers will still stand a very high risk of losing these pregnancies.
Okay.
Yeah.
So you talked of the uterine factors, the congenital abnormalities, the septate uterus. do fibroids and things like adenomyosis play any role in pregnancy losses?
Yeah. The evidence that we have is rather not conclusive, but what with the data that we have, especially in line of the fibroids, we know that submucosal fibroids, these are fibroids that are encroaching onto the cavity of the uterus, the cavity where the baby settles, have an influence on the capacity of a pregnancy to establish very well. Just as much as the intracavitary ones do. Intracavitary myomas are those that are inside, that are within the cavity of the uterus, where the baby settles. These occupy space, affect the capacity to implant, given that within the uterus, normally there's that area called the point of maximum implantation, where the best implantation of a pregnancy happens. So if that space is compromised by the presence of these intracavitary or submucosal fibroids, then there is an effect. But not just the fibroids, even polyps, especially when you have a polyp that is above 1 centimeter in size, it would do that. But also we have a disorder called endometriosis, with one of its forms as adenomyosis. This is like a cancer. It doesn't really go away.
Yeah.
It's usually a fight. It's one of the most debilitating conditions that we've had to deal with as gynecologists, trying to provide therapy to our patients in terms of conception. It's a massive challenge because it's associated with a lot of inflammation, not just outside or not just inside the cavity of the uterus, but also inflammation on the ovaries, inflammation of the eggs. So even with that disease, even if you are of a normal, or you are of a good age in terms of fertility, the quality of the eggs that you're producing is not as ideal because of the continuous inflammation and the toxins that are coming from
the endometriosis.
And then you end up with compromised capacity to really carry pregnancy to viability. Yeah, but again, there is also a role of infections. When it gets to the cavity of the uterus, that's what we call endometritis.
Yes.
Much more specifically, chronic endometritis.
Yes.
The commonest causes would be chlamydia, would be Neisseria, the same bacteria that causes gonorrhea. The good thing with those is they seem to respond better to medicine, and with complete treatment, usually the outlook is much better.
Okay. So talking of infections, where do the torches come in this situation?
Yeah, the torches, that's toxoplasmosis, rubella. Rubella is same as what we call German measles and cytomegalovirus.
Yes.
We don't have concrete evidence in terms of recurrent pregnancy loss.
Yes.
When it comes to the torches. However, what we know is that when you get those infections in an ongoing pregnancy, especially early on in the first trimester, in the first 3 months, in the first 12 weeks when the baby is being formed, then the outcome is bad. Most of the time you'll get a miscarriage, but if you survive a miscarriage, then those are babies that are challenged.
Yes.
And the abnormalities that are mostly manifested by those babies, unfortunately, are abnormalities to the most important parts of the body, like the brain, like the heart, like the eyes. So it's not one of those complications you really want to deal with.
Okay.
Okay.
So, Dr. Meda, the causes and the risk factors for recurrent pregnancy loss are quite immense.
Yeah.
I read somewhere that despite all these causes, about 50% of the couples you may not be able to find an unidentifiable cause. I wonder, as in, how devastating could that be to the patients? Because you're losing a pregnancy, all these tests are being done, and you can't find an identifiable cause.
Yeah, and that's the most unfortunate part about this difficult experience. And of all those risk factors, the worst prognosis comes in terms of how many pregnancies this mother has lost.
Yeah.
You realize that the more you lose, the more devastating it gets.
Yeah.
But the more you've lost, the more likely it is that you lose again. It's just like being in between a rock and a hard place. And much as we will do these investigations, most of the time these results will not return
With
a diagnosis, an obvious cause. But as a clinician, sometimes you ask yourself, should the patient really wait to lose 2 to come to you? Or should you wait for somebody to lose 3 for you to start investigating for possible causes? You know, that's the challenge that we have.
Okay.
Yeah, but what we know is the more you lose, the more likely it is that you lose again. Yeah, that's
Quite a tough situation. So, what are the basic investigations that these couples can do to try and identify the possible cause why they are losing the pregnancies?
For those where the causes may be identifiable, usually history will tell you. For example, patients who have this recurrent pregnancy loss as a result of an incompetent cervix, or as a result of cervical incompetence, normally the history is diagnostic.
Yes.
But also, as you investigate them, a transvaginal scan normally is key, and usually it will show you a cervical length of less than 2.5. But even those that are already pregnant, like we said, usually these are mothers who lose these pregnancies when the pregnancies are well in their, third, fourth, or fifth months. Normally, as you do these serious scans, you will notice that the cervix is progressively getting shorter. Yes. But even when it's not getting shorter, there's something called funneling, where the outer opening of the cervix is actually open, or rather closed, but the inner opening of the cervix is actually open. So then it gets shaped like a funnel, and normally on a keen sonographer will be able to figure that, will be able to pick that out on a routine scan, and that will alert you, and you might provide therapy that changes everything.
Okay.
But also, we have risk, like we've come up with the high risk groups. We have patients who have these endocrine disorders like hyper or hypothyroidism or diabetes, or mothers who have PCOS. Now, there are specific tests that can be done in that case. Normally with hyper or hypothyroidism, you want to do, or Graves' disease, you want to do a hormonal test called TSH to look at how well functioning their thyroid gland is doing. But most of the time, these mothers will actually have normal functioning tests on thyroid gland function assessment it helps to do a TRAB, thyroid and thyroid peroxidase antibodies.
Yes.
Yeah, even when they have normal thyroid function,
yeah.
when you do the antibody titers, usually you may find that the values are high.
Yes.
And those are patients where therapy would really come in handy.
Yeah.
Yeah, but also patients who have diabetes that's not probably been diagnosed, or it's been there but maybe it's poorly managed. Then you would also pick up the diagnosis and you provide therapy, and that would change the course of events.
Okay.
Yeah. Where you suspect maybe uterine malformations, usually transvaginal scan, 3D, 2D scan
Okay.
is really handy. But also we have other interventions that could help, such as sonohistography or hysterosalpingography. We can also do hysteroscopy.
Yes.
The good thing with hysteroscopy, it would be the gold standard, because you're able to diagnose and treat some of the disorders in the same sitting.
Yes.
There is also a role of an MRI, which can also be done, and it would help us pick up some of these diagnoses.
Okay.
Yeah.
Is there a role for karyotyping? Do we need to karyotype some of these couples?
Yes, there's a role
Yes.
for karyotyping, especially when it comes to one. See, we talked about pregnancies that are lost before 20 weeks. Now, for pregnancies that are lost below 6 weeks, sometimes it's very hard to pick fetal pregnancy tissue. But usually for pregnancies where a heartbeat has been demonstrated, which is usually after 6 weeks, you are able to pick fetal tissue and you can subject it to karyotype C. And usually when you get results and those results are suggestive of a genetic disorder, those are couples that would really benefit from karyotyping.
Yes.
Such that they can benefit from genetic counseling.
Okay.
Because in as much, actually, the data that we have at embryoscopy for pregnancies where the fetus has already been formed and there was a heartbeat, and for some, along the course, this fetus is lost, the life is lost, in as high as 84 to 95%. At embryoscopy, structural abnormalities on these fetuses have actually been picked out.
Okay.
Yeah.
The population outside there seems to think sometimes that maybe my blood group doesn't match with my woman's blood group. Is there anything with the blood groups apart from maybe rhesus incompatibility?
Generally, the evidence that we have points more to rhesus incompatibility than anything else.
Yes.
And rhesus incompatibility, the complications are much more common in the Caucasian population, the Israelites, unlike us in our blacks, the African race.
Yes.
But still, there's a risk. And this risk of rhesus incompatibility stretches from as early as an early miscarriage,
Yes.
an early pregnancy of 4, 5, 6 weeks, to exposure at a late pregnancy in terms of delivery. That's why you routinely, when you have a pregnancy that is above 6 weeks and it's lost, and there's a risk of rhesus incompatibility depending on the parents' blood groups, then it's very key that you provide anti-D as a not a prophylaxis, as a presumptive counter to possibility of rhesus isoimmunization.
Okay. Dr. Med, I've seen a few couples with this rare condition, antiphospholipid syndrome.
Yeah.
How does it come in?
Now, as one of the causes for recurrent pregnancy loss, we have antiphospholipid syndrome. So in antiphospholipid syndrome, you have your own body generating antibodies against self.
Okay.
And those antibodies in those patients who have been diagnosed or who have antiphospholipid syndrome, the recurrent pregnancy losses tend to be some of the common complications that they will present with, in just as much as they tend to get issues with blood clots. When they are pregnant, there are mothers who will tend to get preeclampsia.
Yes.
But also they have had, or they tend to be predisposed to getting kidney complications. And sometimes they get, clots under the skin and things like that.
Yeah.
Yeah, and normally when a patient presents with features that are suggestive, then you want to do tests, and normally we do blood tests. We do the anticardiolipin antibodies and the lupus anticoagulant.
Yes.
And normally the titers will be diagnostic.
Okay.
And usually when you're able to make a diagnosis, then you're able to help them, because there is therapy that we have that's promising when it comes to those specific patients.
Okay. Well, among the causes, I know we've talked about the causes. They are quite immense. Is there an absolute cause that, well, if you have this, you may not be able to carry a pregnancy? You may have to bring in surrogacy. Do we have something like that?
Yeah, it's mostly to do with endometriosis. Endometriosis or adenomyosis, especially. Of course, it's always desirable for a mother to carry their own pregnancy, both, medically, legally, socially, psychologically. It's the ideal. It's very desirable, but also economically, because it's cheaper.
Yes.
But there are times when these mothers just won't be able to carry a pregnancy successfully.
Yeah.
Sometimes they are not able to carry these pregnancies, rather to conceive naturally, and maybe you have to bring in assisted reproductive therapies to help them conceive. But even when they do conceive on ART, they are still not able to carry these pregnancies successfully.
Okay.
And there comes a point where you really can't keep forcing the issue, because every time these mothers, these families carry pregnancy and it falls through, it leaves them worse than where you started. And remember, you weren't starting from a good place either.
Yeah.
So it's very devastating.
Okay.
And in terms of, severe endometriosis, severe adenomyosis, where you've had trials and you're not successful, it does help sometimes to consider the use of a surrogate. Yeah.
Okay. Well, listeners, we are still talking quite a deep conversation. So, well, the causes we've seen, they are quite numerous. Some of the causes we are unfortunately unable to identify. So, when it comes to management, is it as simple as treat the cause?
No, it's not as simple as treating the cause. But maybe before we manage, we want to look at what's easy out there that can be done to possibly reduce the risk of us ending up with recurrent pregnancy loss. And these are, may be medical interventions, but others may be lifestyle modalities that we could, adjust, we could change.
Definitely.
Like cessation of smoking.
Yes.
it's very, very key, like stoppage or reduction in alcohol consumption, but also starting to plan pregnancies, such that some of the right assessments are done, but also preconception care, pre-pregnancy care starts in time. And in this case, you're looking at supplementing these mothers with folic acid. As small as the tablet might be, it goes a long way into reducing the risk of these pregnancy losses.
Okay.
And usually we want to start it 2 or 3 months before conception.
Yes.
But also, for example, in mothers with antiphospholipid syndrome who may benefit from aspirin therapy and coagulation in terms of giving them, heparin, you want to start the aspirin, before conception. But you also want to start the heparin therapy as soon as they return a positive pregnancy test.
Okay.
Yes. But also, obesity.
Yes.
Obesity, excessive weight, vis-a-vis the body height. Normally we define obesity if you have, we say you're obese, if you have a BMI that is above 30. But it's not only obesity, even mothers that are underweight, those that have a BMI that is less than 18.5, we would know, would talk to them, would link them through a nutritionist, such that we see which forms of advice would come in to really help us bridge the gap. And that could really avert and otherwise would be an adverse pregnancy outcome.
Okay.
Yeah, so now
And,
that's general but
management.
much of the treatment is more, much of the treatments would depend on what the cause would be. In terms of an incompetent cervix, then you have a role of either progesterones or cervical sacral or McDonald's stitch insertion. If the patient has hypothyroidism, then you're going to need to use levothyroxine to correct the hypothyroidism. If it's hypothyroidism, then you want to use medicines to make these mothers euthyroid. It depends. Specific treatment is more specific to the different causes. If some mother is carrying a uterine malformation that is predisposing her to those pregnancy losses, then there's a role for surgery. There's a role for metroplasty, though the evidence seems to be conflicting in terms of optimizing outcomes. But we have patients that we helped done these hysteroscopic resections, hysteroscopic metroplasties, and we've come out with better pregnancy outcomes. So the treatment varies depending on what the risk factors are and what the possible causes are for these different patients.
Okay. So that makes the need really to at least have these investigations done.
Yeah.
And get the cause and treat it, because like we've seen, the causes are really, really immense. Well, there's as we conclude, there's been a lot of questions that we've met on our podcast. Something about a blighted ovum.
Yeah.
Dr. Miller, just a brief highlight. What's a blighted ovum?
No, a bleated ovum, we commonly would diagnose it at about 7 weeks. Sometimes you can even be able to diagnose it at 6 weeks, because we know that on an ultrasound scan, if the sac diameter, the size of the pregnancy, of the sac that's carrying the pregnancy, if it hits 2.5, centimeters, then we should have a fetal heart.
Yes, definitely.
So if you measure your sac diameter and on a transvaginal scan and you can't pick a fetal heart, then you know there's a problem.
Definitely.
Usually we advise our patients to get a repeat scan.
Yeah.
You know, sometimes when it's that, you want to avoid the effect of bias, so you would call in a colleague to also take a good look, such that the right diagnosis, a concrete diagnosis can be made.
Okay.
But in simple terms, a bleated ovum is a pregnancy where the fetus or the baby doesn't really form.
Okay.
Yeah. Much more common in women above the age of 35.
Yes.
But also with partners who are above the age of 35, much more common, a little less common in younger couples between the age of 20 and 30.
Okay.
Yeah, it's one of those very depressing diagnoses. Unfortunately, the same patients tend to get them.
Yeah.
And sometimes with all the efforts and all the interventions that you would put in place, things seem not to change.
Yeah.
Yeah. There are these drugs that are on market that seem to give promise of a pregnancy progressing to viability. Those drugs come in form of, they are called progesterones. They come in oral preparations. Some are injectable preparations. Others are transvaginal preparations. The evidence that we have is such that those drugs have promise after you've been able to demonstrate a fetal heart,
Yes.
a pregnancy. And the oral progesterone is what seems to actually have better results. The oral progesterone comes in the brand of Dufaston,
Yes.
as compared to all the other preparations.
Yes.
But bleated ovums are some of the biggest challenges yet that we have to deal with in our regular fertility gyne obstetric clinics.
Okay, thank you, Dr. Medet. Well, as we conclude, I want you to, what's your message to a couple out there that have maybe lost 4 or 5? Because I've seen couples that have even lost 7 pregnancies. What's your message to these people?
It's unfortunate what they've had to go through. We know it gets worse with every pregnancy they lose. It gets worse. But the need stays.
Yes.
And because the need stays, no matter how many you've lost, because the need stays, we have to reach out.
Okay.
They shouldn't lose hope. They need to reach out to us such that we give them the best that we can.
Okay.
We have a whole lot of success stories in just as much as we have failures.
Yes.
And it's the success stories that keep us moving. It's the success stories that keep us doing our best, trying to give these couples what might possibly be the best news of their lives.
Yeah.
So you can't, as long as the need is still there, you can't lose hope. Because when you lose hope, you lose reason to try.
Yes.
And when you lose reason to try, you just never know what could have been. So they have to be positive. We understand the challenges that they go through. Some of us as doctors, we probably have also or are going through similar experiences in our own, private lives. So we get it. All they have to do is find a way to pick themselves up and come back to us, such that they give us an opportunity to try again to help them.
Thank you.
Yeah, when it works, it works. It's worked for you 100%.
Yes.
Unfortunately, when it fails for you, it doesn't matter how many successes there are out there.
Yeah.
It's failed for you. But the strength is in repeat trials.
Okay.
Usually along the way, success comes around the corner.
Okay.
Okay.
All right. Thank you, Dr. Medad, for coming to this podcast. Me and Dr. Medad go way back. We've come quite a long way. So people who want to reach out to you, how do they get you? Where is your practice?
Oh yeah, I'm mostly at Roswell Women's Hospital, Roswell Women's and Children's Hospital. I run daily clinics, Monday to Saturday, 7 o'clock to 2 p.m. Any day, any time, as long as it's within those timelines, you'll come in, we'll be able to attend to you. But I also do consultancies elsewhere at Platinum Specialist Hospital. And on Fridays at 2 p.m., you'd find me at Kampala Hospital. But most of my time is at Roswell Women's Hospital.
Okay. Thank you so much, Doc. We are really so enlightened, and we are glad you have accepted this invite. Thank you.
Pleasure is mine.